Dear friends, I have some sort of sore throat. The sound is not very clear, but still I will try to give a talk on approach non-union of long bones as instructed by my close friend Dr. Mangal Parihar. So what do you mean by a non-union? A non-union is a situation where a fracture is not united even after 9 months with no visible progression of healing in the last 3 months. So that is the FDA definition. But whereas, look at this man, his X-ray shows the bone has completely healed. But is it really so? The whole bone is exposed. You can see the whole bone is there. Plate is outside. So it's a atom bomb can break at any moment. Whereas this case, do you have to wait for 9 months to say it's a non-union? It's a distal humerus loss. There's no bone there. So you don't have to wait for 9 months to say it is a non-union. It's a day one non-union. So let me start from the beginning. What happens when a fracture heals? Fracture is happened. How the fracture heals? The gum stored in the marrow cavity leaks out and it sticks the bone ends by forming a callus. Whereas in a soft tissue injury, whether it be traumatic or iatrogenic, the gum is lost. And my professor used to say, a compound fracture as a severe soft tissue injury complicated by fracture. So that is, it's actually a soft tissue injury where the bone is involved, not the other way around, like the bone fracture with a soft tissue injury. We always blame infection for non-union and never think why the hell it is infected. And that is the nature's way. The microorganisms, they control the whole world. And all of you must be knowing what happened with the COVID. So it has controlled the whole world for 2 years. And you know, all the microorganisms are very, very important member of our food chain. And they convert dead and the weak tissues or weak links in the food chain back to the nature for recycling. So can we kill all these microbes with antibiotics? No. They have their own survival skill. We can't win that war by antibiotics. If at all you win it, that will be the end of life in our planet. The only way out is we have to live together. Only living bones can unite. If there is a dead bone or a vascular bone, our body naturally invites germs to get rid of it. Sorry. Many times I feel they are coming and eating the dead tissue and trying to help us. So my view of infection is like this. A devitalized tissue is the mother of infection, and instability is the father of infection, and infection being the baby. If you want to kill the baby, that is the infection by antibiotics, as a weapon, the mother and father will try to resist it. So the best way to tackle is kill the mother by appropriate debridement, radical debridement, and kill the father by appropriate fixation. To give a stable fixation, as I have demonstrated yesterday. Then, if you do these two things, then our weapon, antibiotic, will work better. So, it's a three-prong approach to kill the mother, kill the father, and the weapon will control the infection. So, kill its mother by good debridement and give it no food for germs. Get good living bone in contact. Kill its dad by stabilizing it. Intrinsic and extrinsic stability to counter all the deforming forces by the frame. Only living bone can heal in compression. Because in compression it can heal, and that doesn't need periosteum. So in a trauma, in a compound fractures, or when you do a surgery that area, naturally the periosteum is damaged. When you damage it, and living bone only will heal. But if you want to heal in distraction, we need periosteum to throw callus. So soft tissue must be intact. When you have a good soft tissue intact, like good periosteum, then that fracture can heal in distraction. So what are the fixator options? We have plenty of fixator options, but my favorite is Ilizarov fixator because it is cheap, the best, and axially unstable with three-dimensional control. It's modular one, depending on the situation, you can modify it. A stable fixator, an adequately stable fixator, and most important part is you can span the joint and you can play with it with computerized or duct fix or what sort of deformity correction advanced deformity correction strategies. And you must always remember, learning Ilizarov is like learning a language. Like in a language, you can learn alphabets, grammar, and improve your vocabulary and use it. Nobody can teach you how to write a short story, a novel, or a poem, etc. Similarly, you must learn biomechanics of ring fixators, wires, olives, hinges, and its uses, various permutations and combinations, then use it for our needs. Nobody can teach you how to treat a particular fracture or a particular deformity or a particular non-union. So we have different strategies of treatment for the same type of problem depending on our experience and concepts. Like each one, my language is different from other people. Similarly, we have different Ilizarovs, but the basics must be strong and good. So Ilizarov method means we are using Ilizarov's fixator and his principles. So we can practice it separately also, because this principle can be used for many other purposes, and fixator also can be used for many purposes. And always remember, just putting rings around a limb without Ilizarov's principle is not an Ilizarov method. It's only a ring fixation. Once you are familiar with ring fixation and its uses and got enough experience, you will reach a stage that you will feel the bone is speaking to you. Oh dog, I have this problem. Please help me. So coming to the non-union classification available now, we have one based on callus, that is known as a hypertrophic, oligotropic, atrophic, and pseudarthrotic type of non-unions. That is based on the callus. Now, based on the infection, you have aseptic and septic non-unions. But whereas in Ilizarov, you have only two types, stiff non-union and lax non-union. And infected non-union, again, it comes part of these stiff and lax non-union unit. It's just a sub-classification like sort of things. So, as I told earlier, the Ilizarov treatment strategy, we have two types of non-unions, stiff and lax, in a broad classification. So we have two different types of stiff non-unions. So type 1 stiff non-unions, they have very minimal jog of movement, like less than 7 degrees of movement at non-union site, and further movement is painful. And when you take an X-ray, radiologically they are normotropic or hypertrophic. As these cases will have a little bit of deformity, normally they are managed by distraction because you have to correct the deformity. With Ilizarov, deformity correction is usually done by distraction only. And it will definitely heal by compression too, because these hypertrophic non-unions they have good callus there, good soft tissue there, good periosteum there, it has become a non-union just because of the mechanical problems, a lack of mechanics. So this is an example, a type 1 stiff non-union with deformity, with sclerotic bone ends. Here we can see the sclerotic bone ends. You can see a small tiny sequestrum. A tiny sequestrum there and a tiny sequestrum here, but there is no sinuses anyway. So for an Ilizarov surgeon, clinically, there is no indication for opening. And this sclerotic bone is actually a secondary sclerosis due to the mechanical stress around this area. The bone is trying to prevent, prevent troubles there and getting more stronger around that area. So what I did was, I just put a fixator and asked the boy to slowly correct the deformity. So he corrected it himself, and that is after full correction of the deformity. So he is simply working on that, and that is the X-ray. Now look at it. Where is the sclerotic bone? And you can see the whole medullary cavity is reformed. That is his function, before and after. This is again an oligotropic non-union, clinically like stiff non-union. I just removed the implant and put a fixator and slowly corrected it without anything in it. And that was his final result. And he can even squat on the floor. Now going on to the type 2 stiff non-unions, they have little more movements at the non-union side, more than 7 degrees. And they are not very painful on stressing. You can feel the movement, abnormal movement there. Deformity, if present, is usually correctable. Radiologically, it may be normotropic, or even some extra hypertrophic callus may be there. But these may not heal well by distraction alone. And usually they are compressed initially to convert it into type 1 non-union, and then we can do distraction or compression as you like. So compression converts the type 2 stiff non-union into type 1 stiff non-union. This only works when the periostem is intact. Then to union by distraction or compression, whatever way you want. I'm giving you an example here. A type 2 stiff non-union. You can see the callus, some sort of callus there. But you can see the old infected scar and the black colored post-infective sequelae. It was an original case of interlocking nail for probably a fracture shaft of femur that got infected, and the screws backed out, and the nail entered the knee joint, developed septic arthritis, and knee was completely stiff. And later the nail was removed. So I have tackled at this stage. So I have converted it into type 1 stiff non-union just by compression for about 3 weeks. Then slowly distracted 0.25 millimeter 2 times a day and got his length back. He has completely healed well and got his length back. This is again, I have shown this case earlier. This is again clinically, there is a hypertrophic non-union. A non-union, hypertrophic non-union clinically, a shear non-union there, another shear non-union here. This has become a non-union only because of lack of mechanical stability. So this one can be controlled by appropriate olive wire here, and olive wire here, and olive wire here. You can stabilize everything well. And you can see the olive wire there, and this olive wire, and all were compressed together. And he started working on 3rd day, and within 4 months, the frame was removed. So this is a torsion wedge non-union. You can see this butterfly fragment. One half is healed. The other part remains not ununited. Posteriorly, it is healed. But his issue was the angle impingement because it's already in flexion and you can see the equinus and valgus. So if you remove this nail, definitely is going to break here. So what is the strategy now? I have to remove the nail, remove the screws, do an osteotomy here, correct the malalignment, and fill the defect by bone grafting. So that is what I have done. I did an osteotomy there, corrected the deformity, and filled the gap by appropriate bone grafting. And that is the final result. You can see that side is much more straight than the opposite side. Now coming to lax nonunions. So lax nonunion, we have three types. One is a synovial pseudarthrosis. This synovial pseudarthrosis is actually the final stage of a hypertrophic nonunion. Hypertrophic nonunion evolves either into a malunion or a synovial pseudarthrosis. And the other type is an atrophic nonunion or long fibrous nonunion. And the third one is an infected nonunion. So I'll show you one hypertrophic nonunion. You can see the hypertrophic part and pseudarthrosis here. Hypertrophic nonunion and evolved into a pseudarthrotic part. So what happens is the periosteum converts into a synovium and the bone ends gets rounded off and small pieces of bones like small rice body like thing will form there and you can see the joint cavity and the pseudocapsule. So this is atrophic nonunion where there is no connection between the bones. So what happens, you can translate it into medially or laterally, whatever way. You can bring it anterior, posterior, medial or lateral. It's a multi-directional translational movement and absolutely painless. In Ilizarov, the treatment of pseudarthrotic nonunion, atrophic nonunion or septic nonunion, all these three are the same. Just debride them, align them and stabilize them. And convert, by that procedure, convert nonunion into a gap nonunion. And now you manage the gap by shortening or lengthening at a different level. So, for example, this little girl with pathological fracture following an osteomyelitis. You can see the pathological fracture, which was managed by a external fixator like this, spanning the epiphysis. So see these two pins are perfectly parallel. See now what happens? The pin, that is the power of epiphysis. It is actually bending the pins on both sides and it was the fracture side got absorbed and you can see a big gap there. And it was debrided and gradually, naturally debrided or debrided by surgeon. I don't know the details. And the tiny girl, there is no space for doing anything. So I sent them back to the surgeon who referred the case to me, asked them for removal of the external fixators and a temporary slab. And I planned for acute docking and frame later. They came to me again. So I docked it to improve the stability. Just made a small hole, put that spike of bone into this hole and stabilized it with 3 pins on the top, 1 olive and the 1 pin here, and cavities without touching the epiphysis and span the knee joint. I don't want any trouble there. Span the knee joint like this. And it simply healed, quickly healed, and the child was walking. So that is how it has healed. But the epiphysis already got damaged. You can see the epiphysis creating trouble. So this is a later on X-ray. It has gone well. She got about good range of knee movements like this. She can bend it. This is how she was walking. But definitely she needs some procedure later. So we have been always taught earlier that infection burn in the fire of regenerate. And I have done corticotomy to burn the non-union or to create the fire. And learn it rarely create the fire. So this is my learning case. I let the corticotomy burn the infection. So there is a sequestrum, small, tiny sequestrum there. So these things. So I didn't do any debridement. I stabilized it. I did a corticotomy and tried what is going to happen in this case. In about 6 months' time, it is completely healed. 3 to 6 months' time, it is completely healed. But he ate my brain for nearly 2 years. Because you can even see a small sequestrum there. So 2 years he was pouring out pus, coming out and creating trouble to me. So then I learned there's no point in doing a debridement, a corticotomy to burn the infection. I would like to do a knife for that. It's better to rely upon this fire, not on this fire. Trust on modern concepts of infection management like debridement, antibiotic therapy, and adequate stability using Ilizarov's fixator. The indication for corticotomy is not to create the fire, but for lengthening. It increases the vascularity, there is no doubt. Many a time, as I've shown one case yesterday, it works like a defunctioning osteotomy on a shear non-union. When you have a shear non-union somewhere down and mechanical reason it goes for non-union, do an osteotomy on the top, the shear force will be eliminated and both will heal. Now, why do you want to open a non-union? If you want to remove something like a sequestra or implant, you have to open that area. There's no way out. If you want to put in something like bone graft, you have to open that area. If you don't like the shape, again, you have to open that area. So bone ends, this is a stable situation. This is a stabilizable situation. All these three are not a good bone ends. You either convert them into any of these sort to get the good intrinsic stability. So by that procedure, you convert them, you make them a gap. And now you must use the techniques to manage the gap, either by shortening, lengthening, or bone transport. So this is a case where you can see the docking is not good. Intrinsic stability is bad. And soft tissue is covered by a flap. And I have opened it, docked it together. Post-operative X-ray shows there is a deformity. As my frame is strong, it's not a problem for me. I have corrected the frame and made the limb into full aligned, and I did the corticotomy on top for lengthening. So whatever shortening it happened here, I did a lengthening. I have not done any open bone grafting from anywhere. Local graft this may be reapplied. So now you can see the frame is deformed, but the limb is straight. That was how after healing, the bone is straight, it is completely healed. You cannot even find out any translation deformity there. That is after remodeling. This is a 19-year-old boy, the grade 2 compound fracture, distal femur, and a tibial condyle fracture. He was treated by lower tibial pin traction for 2 months, and you can see good amount of callus forming there. He came to me, so I just carefully resected that part and put a ring fixator. I didn't correct the deformity and used the SUV, not SUV, this is a hexapod, used the hexapod to slowly correct it, but without disturbing the callus. I got the correction. So this is how the callus is. And this is how it has healed. It healed well in 3 months' time, but the stiffness did not improve. That was his movement. You can see the range of movement from there to here. So that case again, he had a limb length disparity because of all these things. So he anyway has to do a tibial lengthening, being a young boy. So I was doing a tibial lengthening for him. At that time, I did a Jude quadriceps plastic. I released all the quadriceps and that much flexion I got. Put a frame, and with the frame, no, this is a tibial frame. I spanned it across the knee joint with 2 pins on the top. And one day I can keep it in full flexion like this. The other day I can keep it in extension. At the same time, I can do the tibial lengthening there. So this spanning the knee joint part is done maximum about 6 weeks, and removing the above knee part in 6 weeks time, so that you will get the knee movement. There is no other way by which I can keep his knee in this more than 90-degree flexion. So this is ultimate end result for him. He can squat well. You can see because the tibial lengthening is butts are a little bit higher. Now look at this, a different case where a stiff non-union with deformity. There is an oblique plane deformity valgus, there is a recurvatum and valgus. But it was actually a healed fracture, non-union. The real enemy was a hidden equinus here. The equinus is a dangerous combination. When the patient is walking, if the heel is not touching, his mechanical axis will be going from the femoral head to the first metatarsal head. It will be going anterior. So that can create a fracture of the, partially healed fracture can break. So equinus is a very dangerous one, especially for distal tibial fractures. So I have resolved this deformity valgus and recurvatum into one oblique plane, and this oblique plane and the internal rotation deformity resolved into a new oblique one and made a complex frame like this. You can see the hinge is there on that rod, and in this rod the hinge is here. And this is a distraction rod. This is the rotation which can be corrected by that. So you can see that hinge here, the medial hinge is lower, the lateral hinge is higher. So this is the distraction rod happening. So I can correct it like this. So he has completely got corrected and got the good callus over there. This is the final result. And the equinus is also corrected. That is the final result. So gap non-union, you decide what the strategies to be tackled in this case. I done partial docking, then gradual further docking on that. Partially docked it initially, made the gap less. Because you know, these gap non-unions will heal only after getting in contact. So I made it partial docking and then gradual docking and external bone transport. After that, external bone transport. All can be combined. We have to do appropriate strategies for that. And this is for the final trial walking. I just removed the connecting rods. He can walk now. And he was on the frame for nearly 1 year. And he again underwent a Jude quadriceps plasty and got his knee range of movements full. This is a gap non-union. I don't know why they put a LRS on him. It is not being aligned. And even the pins are not the LRS pins. And this was the stage when he came to me. So I removed the fixator and did a corticotomy and tried transporting. As it came down, because the spike, it was deflecting backwards. So it created, you can see the soft tissue has been going into it. And the bones are not in contact. So at this stage, I opened it, took this spike of the bone into the medullary canal. And that's what I did. You can see the final union. And this equinus was corrected. So angle unfortunately got fused, but his function was reasonably good. This is a case where he came to me after 12 days after an RTA. The full area was exposed. You can see the fixators, and the foot was free. Whenever he was moving his toes, I can see the muscles moving beyond the bone. The bone was not holding the bone at all. This was his X-ray and the fixators. Only one pin on this fragment. Every time he moves, this bone also moves. It is a very unstable soft tissue. So I have improved the fixation so that the soft tissues will all supply the bone better. And a partial bursting closure. And you can see the skin is being hooked by K-wires. And all the tricks has been done there. Foot is stabilized on the half ring. This was how it was looking like. And I could save a good amount of bone here. And this is the only part which is lost. Now I did one corticotomy on the top, another corticotomy here, and try to transport the middle fragment. This is initially here you can see all separate rods. Here again you can see the separate rods converted into full length rods, so that this fragment runs on this rod downwards. This fragment runs up along this rod, and finally they'll go together, meet together at this point. You can see it is coming down from there, going up from here to finally to meet at that point. So that gap has got reduced to this much. And once I docked, I removed the straight rod into small rods. The wound has healed, bone and sealed, it was working well, so the foot frame was removed. You can see the final healing. And a happy ending. And without any flaps, anything, we could save his limb. And unfortunately, it was a completely free surgery for him. He is lucky and he can see the smile on him. But I took about nearly 3 months. He was in the hospital without any expense. He was my junior in, I think, 93, 94. He had more than 18-month-old injury. He was posted for ebony amputation. This was the situation. You can see a big gap in the upper end with sequestrum at this area, and there's another non-union here. It's a double non-union. One is a gap non-union, the other is just a non-union, and that need debridement and bone transport. But where to do the corticotomy? Can you do the corticotomy here? Is it possible to do corticotomy there to get that much length? Or is it possible to do a corticotomy at that level? It was we had to discuss upon that and think about it, get ready. So I decided to do a corticotomy at the upper end because the metaphyseal area can throw more callus. But there is no space to hold it. So I used the olive wire to pull it down on a special pulling device. And this is known as an internal bone transport. The earlier one I've shown was an external bone transport. I kept a dummy ring there so that when the fragment comes down, I can catch that fragment here for compressing with the the distal bone. So you can see the regenerate has formed well. But unfortunately here, the distal fragment was not healing at all. So this took nearly about 10 months for completion. But even by about 8 months, there was absolutely no callus at the distal non-union side. Finally, I decided to distract it. So as I distracted, the whole thing has healed. That is his clinical picture. You can see distal is healed, the proximal healed. He is on a trial walk. All healed well. So this is again another a 25-year-old lady with complex deformity there, and another deformity there with limb disparity, so many surgeries. And yes, she had a Ilizarov and orthofix and all those things. So how to tackle this? The main issue is a malalignment. She was advised an ebony amputation. There's no other way. And I did the planning like this, just a preoperative deformity correction planning with one corticotomy there. If I want a lengthening, I do the lengthening here, straight lengthening, and non-union at that level. So this was my preoperative planning. If I can get it like this, probably there's a chance of healing. I made a frame back to Ilizarov, the Nonunion side in the upper end, and the middle for deformity correction, and distal for length. So this is after realignment. You can see the lengthening there. This is the deformity correction plus lengthening and the compression of the non-union side. And this was how the X-ray was looking like. I mean, the clinical picture. You can see here, the middle rings are not perfectly parallel because the lack of intrinsic, the stability there, because only that fragment was holding only with one ring. You can see that ring is not a, because the single fragment has to control everything. So I have to do a little bit over, there is a fixator loss in that fragment. But even with this, you can still get a perfect alignment like this. So this is your planning before, this is the result you got. So in certain situations like this, when the microvascular fibula, everything has lost, you can see the microvascular fibula got infected. That was the X-ray looking like. But this patient had a normal fibula on this side. I decided to do an osteotomy at that level, another osteotomy here, and transfer the fibula slowly to the tibia. Tibialization of the fibula. So this was how my fixator plan was. One only wire here, one only wire here, and gradually pulled it on a device like this. You can see it is coming into the tibial part along the syndesmotic membrane. So it has come there, then I have docked it. And that is how it has healed. So this is called slow fibular transport. So by this talk, you must have understood that it is not the fixator which heals. It is our strategy which heals a non-union. Make a good stable frame to implement your strategy and help the bone to heal. So make an appropriate strategy and use the Ilizarov principles and its fixator for implementing your strategy. You will succeed. So the decision making in a clinical situation is a complex one. There is no cookbook method. You strictly adhere to intrinsic and extrinsic stability, axial alignment, vascularity, and function. Mother Nature will heal it. So in principle, it is simple. Distract type 1 stiff non-union, compress type 2 stiff non-unions, and convert it into type 1 and then distract SOS. Synovial, atrophic, and infected non-unions are all converted into a gap. And then treat the gap by appropriate method. One is comfortable and dependable with. I've shown most of the methods. Thank you.